there, my name is Dr. Jeremy Cotliar. I'm a glaucoma specialist and comprehensive ophthalmologist based out of New York, and I'll be going over the glaucoma update looking forward to 2023. Disclosures: I have no financial disclosures. The content and format of this course is presented without commercial bias. So as a refresher, what is glaucoma? Glaucoma is a disease of progressive optic neuropathy with loss of retinal neurons and their axons, the nerve fiber layer, resulting in blindness if left untreated. It describes a group of diseases that kill retinal ganglion cells. High IOP or intraocular pressure is the strongest known risk factor for glaucoma, but is neither necessary nor sufficient to induce the neuropathy. So how many lives are impacted by glaucoma? More than 3 million Americans suffer from glaucoma. Here's just a little picture. On the left is a perfectly normal vision with the eyes. And then on the right side, you start to look through a central vision with loss of peripheral vision, which is typical of glaucoma. So who is a glaucoma suspect? Anyone with elevated or asymmetric IOP or high intraocular pressure, a suspicious disc appearance, thin optic nerve rim, a cup to disc ratio greater than 0.5, cup to disc asymmetry between the two optic nerves of 0.2 or greater, a suspicious retinal nerve fiber layer or RNFL, and as we can see in the picture to the left, a disc hemorrhage. Other risk factors for glaucoma: positive family history, history of trauma, advanced age, African American race, phakic people who have not had cataract surgery as of yet, and hyperopic eyes. So this just goes over the basic trials for glaucoma, the clinical studies. I'm not going to bore you with that. I'm sure you guys can look at the slide and study it. Appropriate techniques for evaluation of glaucoma. So there's 5 major components of the comprehensive eye examination that are specifically relevant to assess glaucoma. The slit lamp examination, specifically in this instance to rule out any secondary causes of glaucoma. Intraocular pressure measurement, whether it be with a Goldman applanator or an eye care tonometer. Gonioscopy, which is the lens that goes on the eye to look at the structures of the angles. Disc and retinal nerve fiber layer examination, such as an optic disc examination, photos, and an OCT of the retinal nerve fiber layer. Perimetry, such as the Humphrey visual field, which is the visual field test, the test for peripheral vision. And central corneal thickness, such as pachymetry. So let's go through each one by one and go over the basics. So on the left, you see a slit lamp examination with a doctor using a lens to assess the posterior pole of the eye and the optic nerve. Measuring intraocular pressure, on top is the Goldman applanation. That's the blue light that touches directly on the cornea. It's the most accurate measurement of intraocular pressure. And on the bottom is the eye care tonometer, which is also it's accurate, but not as accurate as the Goldman applanator. Gonioscopy, there are many different types of gonioscopes, but in this case, this has a handle on it. And you're looking at each mirror to look at the opposite angle to assess how open or narrow the angle is. So assessment of gonioscopy. So going from the iris up, you have the iris. You have some iris processes going over the scleral spur. You then have the pigmented trabecular meshwork, the non-pigmented trabecular meshwork, and then finally Schwalbe's line. So an open angle is usually when you can see the ciliary body band as well as the adjacent scleral spur. And if you'll notice in this picture, there are some iris processes spanning over the scleral spur into the trabecular meshwork. And that is also pathognomonic. It's also indicative of an open angle. Now, narrow angle gonioscopy is seen here, where on view, you really can't see any angle structures. The iris is overlapping the scleral spur, the ciliary body band, and Schwalbe's line. So significance of open angle versus closed angle glaucoma. So in a normal eye, you see the pupil, the iris, the cornea, and the angle is in between the iris and the cornea. So when you have a narrow angle, typically the iris obstructs the angle. And then with open angle, there's some obstruction in the drainage channels of the angle that sometimes we just can't see. And the end result is high intraocular pressure, which then can progress to optic nerve damage. So how does open angle glaucoma present? Primary open angle glaucoma, or POAG otherwise known, also referred to as chronic simple glaucoma, is generally a bilateral but not always symmetrical disease characterized by adult onset, IOP greater than 21 millimeters of mercury, an open angle of normal appearance on gonioscopy, characteristic optic disc cupping, and visual field loss. How does closed angle glaucoma present? This is the steamy, red, hot eye, which is a rapidly progressive impairment of vision, painful eye, red eye, nausea, vomiting, photophobia, halos around lights, transient blurring, history of similar attacks in the past, and chronic angle closed glaucoma, or CACG, is usually asymptomatic due to slow onset of the disease. So optic disc evaluation. The isn't rule, which means that the inferior nerve fiber rim is thicker than the superior, which is thicker than the nasal, which is thicker than the temporal. It's not a hard and fast rule, but it's a good thing to remember when assessing the optic nerve rim thickness, because if the optic nerve doesn't follow the isn't rule, there's a chance that this is glaucoma. So the neuroretinal rim, as we said, in normal eyes shows a characteristic configuration, as we said, inferior, thicker than superior, thicker than nasal, and thicker than temporal. Characteristics of a normal optic disc. The optic disc appears pink with sharp margins and a cup to disc ratio of approximately 0.35. The vasculature is normal and coarse in caliber. The striated sheen radiating outward from the disc is evidence of a healthy retinal nerve fiber layer. And that's indicated with the picture on the left. Characteristics of a glaucomatous optic disc. Characteristic features of glaucomatous optic nerve include generalized or focalized increase in the optic cup size and in the cup to disc ratio, vertical enlargement of the optic cup as a result of retinal nerve fiber loss and or disc rim loss, especially at the superior and inferior poles. And in these pictures, these are various forms of possible glaucoma. On the top left, you see an inferior notch, which is a focal thinning of the inferior rim, which is typical of glaucoma. In the top right, you see some nasalization of the vessels. The vessels are starting to move nasally as opposed to temporally. And the bottom ones, you have a tilted disc on the bottom left and some peripapillary atrophy in the bottom right. Ocular coherence tomography, or OCT, of the retinal nerve fiber layer, RNFL. Optical coherence tomography, OCT, tests obtain a topographical map of the optic nerve using non-invasive light waves to take cross-section pictures of the retina. An OCT measures the thickness of the nerve fiber layer, which is the portion of the optic nerve most vulnerable to eye pressure elevation. So a normal OCT RNFL, we like to see lots of green. In this picture, there's lots of green. On the bottom, it shows temporal to superior to nasal, and everything is staying above the yellow borderline line, which is indicative of a healthy optic nerve. And in the top blue pictures, we want to see the fire coming out of the optic nerve, and that fire indicates healthy retinal nerve fiber layer. A glaucomatous OCT-RNFL shows lots of red. In the pictures of the optic nerve, it shows the bowing posteriorly. In the blue pictures, instead of having fire, it's pretty much extinguished. And in the retinal nerve fiber layer deviation map, here you see the redness, which indicates thinning of the retinal nerve fiber layer. Ganglion cell complex on glaucomatous OCT-RNFL is just another way to assess glaucomatous optic nerves. We don't want to see red in the picture as we do in the bottom right in the OS deviation map. That's just another way to assess glaucoma. AAO glaucoma severity staging descriptions. So mild glaucoma is indicated by optic nerve changes consistent with glaucoma, but no visual field abnormalities on any visual field test, or abnormalities now is present only on short-wave automated perimetry, SWAP, or frequency doubling perimetry, FDP. Moderate stage is optic nerve changes consistent with glaucoma and with the start of glaucomatous visual field abnormalities in one hemifield and not within 5 degrees of fixation. Severe glaucoma is indicated by optic nerve changes consistent with glaucoma and glaucomatous visual field abnormalities in both hemifields and or loss within 5 degrees of fixation in at least one hemifield. Humphrey visual field in mild glaucoma, same as a normalized. You don't see any loss of visual field function in mild glaucoma because it takes around loss of 50% of the axons to start to see visual field abnormalities. So in this case, this could be a normal person or it could be a mild glaucomatous person. In moderate glaucoma, you start to see some pattern deviation on the bottom right depression. In this case, it's the inferonasal defect. So we call this an inferior nasal step. And by definition, because it's not within 5 degrees of fixation and because there is a visual field defect, this is characterized as moderate glaucoma. And then in advanced glaucoma, you could see a superior hemifield defect like you see on the top pictures, which are involving the central vision. You also can have central island, which you can only see a tiny little bit through the center, but everything else is extinguished, as you can see on the bottom picture. Now, pachymetry. This measures the central corneal thickness. So what is normal corneal thickness? An average cornea is between 540 microns and 560 microns. A thick cornea is 565 or more, with a very thick cornea being greater than 600 micrometers. So what is the correction for IOP based on central corneal thickness? Central corneal thickness helps us determine how accurate our IOP measurements are in the office. It's not a hard and fast rule, but we know that the thinner the cornea, the greater chance of progression of glaucoma, and it means that the pressures that we're measuring are actually more than what we're measuring. And vice versa for thick corneas, the thicker the cornea, we subtract the number from the IOP, and that is what the actual pressure is in the eye. So now we're on to glaucoma therapies. So therapies for glaucoma, we have eye drops, we have laser, we have MIGS, the minimally invasive surgeries, and incisional surgery. So glaucoma eye drops, the monotherapy drops. So I just put some pictures here of the typical drops that we use. And I tell my patients, look at the color of the top, because even if they're different drops in the same class, they're going to have the same color top. So in the top left, you see Xalatan, Lumigan, and Travatan, and they all have turquoise tops. Those are typically given at bedtime in both eyes. Then you have the purple top, which is the Alphagan or Brimonidine. The yellow top is Timolol or a beta blocker. The dorzolamide is the orange top or the carbonic anhydrase inhibitor. The Ropressa is a newer medication, which we'll go into. It's the white top, also given at bedtime. And then the older medication, pilocarpine, is actual green. It's an older medication which constricts the pupil and is semi-effective in lowering the intraocular pressure. And on the top right, you see Vyzulta. Vyzulta is similar to a prostaglandin analog, which is the top left drops, but it's got nitric oxide. So there's vasodilation, and it should help lower the IOP even more. Then we get to the combination eye drops. So on the top left, we have dorzolamide timolol, or Cosopt, and it's the dark blue top, similar to Combigan, which is the timolol and brimonidine, Simbrinza, which is brinzolamide brimonidine, and Rocklatan, which is the newest one, is Ropressa and latanoprost mixed together. So here's a little cheat sheet for mechanism of action of main glaucoma drops. So the drops that increase trabecular outflow are the parasympathomimetic agents such as the pilocarpine, the prostaglandin analogs, like we discussed with latanoprost, Travatan, and Lumigan, and the newest Rho kinase inhibitors, Ropressa and Rocklatan. The ones that increase uveoscleral outflow are the prostaglandin analogs, as well as the alpha agonists, the brimonidine. And finally, the ones that actually decrease the aqueous production are the beta blockers like timolol, the alpha agonists such as the brimonidine, and the carbonic anhydrase inhibitors like the dorzolamide. Selective laser trabeculoplasty, SLT. People more and more, glaucoma specialists in particular, are using SLT as first-line therapy versus drops more and more as time goes on. So the pearls of SLT. It's increasingly used, as I said, as first-line therapy to lower IOP by glaucoma specialists. SLT uses short pulses of low energy light to target the melanin or pigment in specific cells of the affected eye. In response, the body's natural healing mechanisms go to work to rebuild these cells. This rebuilding process improves drainage and lowers intraocular pressure. The surrounding non-pigmented cells, as well as the rest of the eye structure, are untouched and undamaged. When used as first-line therapy, it may decrease the IOP by up to 30%, which is equivalent to 1 glaucoma drop. Now we get into the micro-invasive glaucoma surgeries, the MIGS procedures. So the benefits of MIGS: safer than incisional or invasive glaucoma surgeries, provides mild to moderate IOP lowering, may be performed earlier in glaucoma stage and thus prevents the progression to advanced glaucoma. So the first MIGS I'll talk about is the Omni from Sight Sciences. As you can see the device on the left side of the screen. It targets all 3 levels of aqueous outflow resistance: the trabecular meshwork, which is the trabeculotomy function, Schlemm's canal, which is the canaloplasty function, and the collector channels, which is also the canaloplasty function. So the way it's done is you turn the head away from you, as well as the scope, and under gonioscopic visualization, you bring the bevel, the sharp bevel, all the way to the nasal trabecular meshwork, and you incise the trabecular meshwork. You then send out a blue nylon cord, which travels along Schlemm's canal, and then you retract it back and you inject viscoelastic into Schlemm's canal to dilate the canal and to increase aqueous outflow. Then you have the Cahook dual blade goniotomy, which is one of my favorites. This was the one I used mostly when I first started doing MIGS surgeries. And as you can see, it's a very sleek pencil-like device, which has, which on the left side, you show an intraoperative view of the eye's drainage system as the goniotomy is being performed. And the blade shears the outer trabecular meshwork, thus unroofing Schlemm's canal and increasing surface area of drainage of aqueous humor. The trabectome is one that I used a lot during my fellowship in Irvine, California. It's an electrocautery device similar to the Cahook, where you go in to the nasal angle the same way you do for the Cahook and for the Omni, and you just go across the trabecular meshwork and you electrocauterize the trabecular meshwork, thus also increasing the surface area of drainage and unroofing Schlemm's canal. This is the eye stent. There's been many different generations of the eye stent, and admittedly, I don't do many of these. I did them when they first came out, and I found them to be very difficult to inject. But it seems to have gotten better over time, and now it's up to the iStent inject, where you implant these little snorkels in the nasal angle, which will allow you to bypass the trabecular meshwork to allow aqueous humor to drain into Schlemm's canal. It's very small, as you can see, and I'll go back and say that the Omni can be used as a standalone procedure and in conjunction with cataract surgery. The iStent can only be used in conjunction with cataract surgery. Here we have the Hydrus from Ivantis. So the Hydrus is a scaffolding device, and this is my favorite MIGS procedure. You go in the same way as you do for the other MIGS procedures, and you go in, you incise the trabecular meshwork with the beveled needle, and then you send out a scaffolding device which goes across Schlemm's canal and scaffolds open Schlemm's canal to allow greater surface area of aqueous humor drainage. Here we have the Zen gel stent from AbbVie or Allergan. This is now my go-to device for advanced glaucoma. I used to do lots of trabeculectomies, which I won't really get into here, but that is the surgery where you make a minuscule flap on the wall of the sclera, and then you dissect forward, make a direct connection from inside the eye to outside the eye, and then suture down the flap with interrupted 10-0 nylon sutures. For the Zen, I find it to be a little sleeker and less messy than the trabeculectomies. And in this case, it can be used in two different ways. You can do it from inside the eye towards the outside the eye, or from outside the eye towards the inside the eye. And it's then similar to trabeculectomies, you use it in conjunction with mitomycin C, which is an anti-metabolite, which helps prevent scarring at the surgical site. So here we have the Zen gel stent ab interno approach. So here, you proceed from the anterior chamber through the sclera and into the subtenon space. You want to be very careful not to puncture through the conjunctiva, which is certainly, I find this method to be a lot more difficult, a lot more challenging than the next way that we'll show you how to do it. Here, this is the way I only do it. The only way I do it is the ab externo approach. So starting from the top left, you see, and this surgeon chose not to dissect the conjunctiva, which is not the way I typically do it. I open up the conjunctiva and do cautery and have a nice bare sclera to inject the device. The needle goes through the sclera and goes all the way to the hub. And at that point, you send out the little Zen gel stent, which on the bottom left, you see the Zen going through the sclera, and the other side of it is into the anterior chamber. The process then is to stitch close or suture close the conjunctiva over the Zen, making sure that the Zen is not tangled up in Tenon's capsule, which can definitely happen. And then on the top right, we see the Zen sitting nicely on the wall of the eye under the conjunctiva and is in good position. So now we'll talk about ways to decrease aqueous humor production. And endoscopic cyclophotocoagulation, or ECP, is something that I've used in the past, but I find it to be very damaging to the eye, and it's not very user-friendly. Not to mention, you ablate the posterior ciliary processes, which are not exactly where the aqueous humor is being produced, and we'll go over that in a second. So you can see here, this is in conjunction with cataract surgery. The probe goes through under the iris, and then you look at the screen. You see the screen on the top right, and you step on the pedal, and you watch the ciliary processes shrink and get ablated. So This version of a laser was done way back in the day, and it was only really used for end-stage refractory glaucoma, where the patients lost most of their vision and nothing else has worked. And this is a last-ditch effort to lower the intraocular pressure. So this is cyclodiathermy, or the old CPC laser. It's a pretty barbaric procedure, really requiring retrobulbar anesthesia, as it's very painful. The ciliary body in particular is very painful. And the point of it is to ablate the anterior ciliary processes through the sclera. And as we said before, it was only used for end-stage glaucoma with very poor visual potential and very poor vision. The newer version of the CPC laser, which is one that I also used a lot more in the past, not as much today, because it is very painful, is the Iridex transscleral CPC laser with the G probe. And now it can be used as a MIGS, used for mild to moderate glaucoma, both as a standalone as well as with cataract surgery, to help prevent glaucoma progression. It's a micropulse, which allows the tissue to cool between laser pulses, minimizing or preventing tissue damage, which is very important. And that's really how it differentiates itself from the older cyclodiathermy laser. Treatment risks are reduced or eliminated with increased patient comfort than with conventional continuous wave laser treatment, different than the old cyclodiathermy laser. This is Durysta. This is a newer product from Allergan or AbbVie. It's the first and only FDA-approved dissolvable ocular implant to reduce eye pressure in people with open-angle glaucoma or high eye pressure ocular hypertension. Unfortunately, though I think Durysta is a quality product, the FDA only approved it for 1 injection per eye per lifetime. So really, when I discuss it with my patients, I tell them you can take a vacation from your drops, but once I start to see your eye pressure go up or progression of your glaucoma tests, you'll have to be back on your drops again. Not really ideal, but a lot of patients will opt for the vacation from their drops because the drops have a heavy load of preservative and the eyes are typically very irritated on chronic eye drops. So just one Durysta implant reduced the eye pressure for 15 weeks in clinical studies. I've seen patients in my personal practice where it's lasted 4 months, and I've seen patients where it's lasted 1 month, and I've seen patients where it lasted less than a year. So really, it varies from person to person. As the Durysta dissolves, it automatically releases the medicine to help reduce eye pressure inside the eye. My father, who's also an ophthalmologist, my partner, he's very weary of doing procedures like this because he's very worried in a phakic eye of going through the cornea into the anterior chamber with a needle. He's worried about puncturing the anterior capsule of the cataract or the lens of the eye. I don't find that we go anywhere near the anterior capsule of the eye, so I think it's a safe procedure. So this is a little pipeline for 2023 and beyond. So some glaucoma drops in the pipeline. So examples of glaucoma drops in the pipeline. We have Monoprost, which is the preservative-free prostaglandin. We have NCX470 or Nicox SA. We have Chromacalin Prodrug 1 or CKPL1. We have Omidenipac isopropyl or OMDI from Santen. We have QLS 101 or Claris from Bio. And finally, GS010, the RAV2 2ND4 from Gencyte. So it's a mouthful. So let's go through Monoprost from Thea first. So this is a preservative-free latanoprost. It has long-lasting IOP production. It's, as we said, a preservative-free formulation. 1 single dose container holds enough solution for both eyes. And the benefit as compared to the other prostaglandin analogs, such as Xalatan or latanoprost, travoprost, or Lumigan, is that this the significantly lower hyperemia than with Xalatan or the other prostaglandin analogs. NCX470, it's the only drop in the pipeline from an existing mechanism of action, the prostaglandin analog. It's formed from nitric oxide donating compound. More recently, in 2021, the company reported the outcomes of the dose response phase 2 trial, Dolomites, which showed that patients on this novel drug experienced significantly greater IOP lowering effects than those on latanoprost. This is similar to Vyzulta, as we mentioned before, as that's also a nitric oxide component medication for IOP lowering. Phase 3 clinical trials known as Mont Blanc and Denali are underway, and the results are expected in the first quarter of next year. Here we have Chromocalin prodrug 1, or CKPL1. It's a new mechanism of action. It's an ATP-sensitive potassium channel opener. It reduces episcleral venous pressure, which is very important because episcleral venous pressure is what prevents the angle-based mixed procedures from lowering the pressure to the low teens or single digits. Its increased resistance prevents the eye pressure from going below the mid-teens typically. It's being studied in the United States and the United Kingdom. 1-to-1 ratio of reducing episcleral venous pressure, or EVP, to reducing IOP. 1-to-1, which is great. The existing drops have less than a 1-to-1 ratio. EVP usually caps the amount of IOP reduction by a drop, as we just said, or for MIGS procedures. So it's very exciting that this drop could be equivalent to invasive glaucoma surgery, which we typically need, as we mentioned before, the Zen, trabeculectomies of mitomycin C, which I haven't shown here in the slide deck, as well as a Behrville glaucoma implant. All surgeries that we need to get the pressure down to the low teens, which is where we think advanced glaucoma patients need to be to prevent progression of glaucoma. And this is not yet used on humans. It's been used on monkeys. Omidinipag isopropyl, or Amlanti, it's already sold in Japan and other parts of Asia, but still awaiting FDA approval. It's a selective non-prostaglandin prostanoid EP2 receptor agonist. It's got a better side effect profile than prostaglandin analogs. Studies showing it to be as effective as prostaglandins with better side effect profile. QLS-101, or Claris, similar mechanism of action to CKPL1. It's an ATP-sensitive potassium channel opener, but it's further along in the approval process than the CKPL1 ATP-sensitive potassium channel opener. And this also targets the reduction of episcleral venous pressure, which, as we said before, is what's standing in the way of eye drops and MIGS procedures of lowering the pressure to the low teens or single digits. Both Claris and CKPL1 have better side effect profiles than prostaglandins. GS010, or the RAV2 2ND4. It's not specific for glaucoma and is currently being investigated for vision loss due to Leber's hereditary optic neuropathy, or LHON. It could be the start of gene and cell-based therapies for other neuro-ophthalmic conditions, such as glaucoma, which, if we could find ways to regenerate optic nerve tissues, that would be a major development in glaucoma treatment and prevention of vision loss. It's given as an intravitreal injection, and so far, it's showing positive preliminary results. So here are some glaucoma surgeries in the pipeline. So this is the iDose TR from Glaukos, the same company that makes the iStent. It's essentially a combination of the iStent and Durysta. The iStent, if you recall, is the injectable snorkel, which allows the aqueous humor to bypass the trabecular meshwork and access Schlemm's canal, thus lowering intraocular pressure. In addition to the iStent portion of the iDose, it also elutes a drug similar. It elutes IOP lowering medication, which also helps lower the pressure inside the eyes, and it's so far shown sustained IOP reduction. It's currently in phase 3 clinical trials. Here's the Scion from Sight Sciences, and it's similar to the Cahook dual blade goniotomy, and it's a manually operated device used in ophthalmic surgical procedures to excise trabecular meshwork. Scion's bladeless design, microengineered and precision manufactured, is utilized using specialized lasers, excises tissue without cutting. It's a bladeless device, and similar to the Cahook dual blade goniotomy and the Omni, it can be used as a standalone procedure or done with cataract surgery. Thank you so much for listening, and have a great day.
All right. Thank you, Dr. Cotliar, for a great walkthrough of glaucoma and what to expect as we move into 2023. I hope everyone can agree that we learned some new tips and tricks to manage these cases and inspiration on what's to come from a therapeutic and surgical perspective. Before we conclude this session, I know you all are excited to know the next raffle code, which is DME.